So Sarah, let's start with you. I found myself thinking this morning, there's an imbalance of information in healthcare that with language, with knowledge, certainly things like OpenNotes and the theaters can help put doctors and patients on more of a level playing field, but what's your take on this? What kind of guidance are you giving to the patients that you work with about how to have effective conversations with their clinicians and how to participate in shared decision making?
What a great question. Thank you so much for having me today. And I learned a tremendous amount this morning from our speakers. So the center that I work at is called the Center for Patient Partnerships for a reason. For us to truly transform healthcare, it is about a partnership between patients and providers and employers and other purchasers. So I'm glad that you've brought together the people that you have today. So I agree earlier that patients have an important role, and I am absolutely for empowerment of patients. But the reality is we have to do this together. And so I've been thinking a lot as I was sitting here about what employers can do to assist patients and what physicians can do to encourage the activity. So for example, there is information overload, and both of these resources we learned about today, the theater and the OpenNotes, helps with that information overload. And you as employees can help with that. So the best time for patients to be thinking about their values and what kind of decisions they might make, for example, about whether or not to get tests, is not when they're stressed, is not in the 5 minutes in the room with the doctor when there's very little time, right? So as employers, you can have some incredible education events where people can start to think about what their values are, start to learn about this data using some of these really accessible tools, and become much more empowered so they can be a part of the solution.
Great, thanks, Sarah. You mentioned the role employers can play, and I want to come back to that because I think that, as I mentioned to you both during the break, some minds were being blown during your presentation, I think. We have taken as a given that an annual physical is the right thing to do and the right thing to incent, and our wellness programs encourage, mandate even, taking health risk appraisals and biometric screenings, and we're using that information, we think, in a productive way, but maybe not. And your presentations raised some questions about that today. So I'm wondering if you can comment a little bit more on the use of wellness programs and how it is that employers can be using the leverage we have through plan design, through workplace wellness programs to effectively encourage appropriate use of healthcare services and real shared decision making by patients. Either. Yes.
I definitely don't want to begrudge the importance of an annual or a periodic visit with some type of either health professional or health coach or someone who can help you discern a lot of this conflicting information. I mean, one of the reasons Erik showed all these ads is because we're barraged by them. We're barraged by ads. Again, we're barraged by stuff in the newspaper, which, one day says you should get your blood pressure below 120, the next day says you better keep it above 140, and it just doesn't make sense. So to have someone in an employer's situation that can help know where to access some information, to start that discussion. I find as a doctor that when people come in informed, it makes my job a lot easier. We could have the discussion right from the get-go. In terms of a lot of these, the programs, I see a lot of people that I have to fill out a form, and one of them, you got to check your cholesterol, you got a couple lab tests I have to check, and then they get some money. I don't know how it works, but they get a little extra money if I do all that stuff. Again, I periodically will check people's cholesterol just to make sure they're not outliers, but that's not the focus of wellness. And that kind of pulls us away from what a discussion should be. So someone, in the questions brought up, well, what if you had theaters about the value of exercise, the value of diet? those kind of things would be great to bring in also, when you see your provider. And a lot of that can happen at the place of employment. I think those discussions are crucial there, and they, I think it's much more meaningful, and you have more time, and like you say, you're not under the clock and you're not stressed, and so the discussion would be much better in that setting.
Eric, do you have thoughts about that too?
Well, I think one of the things that might be inhibiting doing something new is just that it's new and that it's different. And can we really safely change the status quo? And in our case, for example, and I know we've said this before, but it keeps coming up, we're not doing any other research. We're simply presenting a way to communicate information. And it happens to be a good way to communicate information based on the responses we've seen in a number of places. So I think people should understand that. They should be perceptive. They should understand it, and they should try it because it is a better way to involve patients in shared decision making. We have a colleague at Johns Hopkins University who defines shared decision making. She published an article which simply said, we're going to try to get doctors to have a more smooth approach, to look better, to dress better, so that they will essentially agree with what we're saying. They won't argue with us. That's not what we're talking about. And I see a major role for employers. I think employers should take the lead and try to use something like we're doing to get patients to understand what they're doing, to get other practitioners to understand. And I don't think it's that big a deal as long as someone's willing to make that next step. People are afraid to move ahead, and they find reasons for keeping the status quo. And I find the Alliance to be a relatively unique group. They're progressive. They are moving forward. They know what is necessary to keep high-value care and to keep costs down and to reduce overtreatment. And if it's not what we're doing, it should be something analogous to it because it's the right thing to do.
Can I just add quickly?
Yes, please.
Because you are a part of the Alliance and because you are offering self-funded plans, you have incredible power of the purse. And one of the things I was thinking as I was listening is if we've got evidence that certain tests do not work, then don't pay for them to be done. And there are processes by which the few patients who would benefit from those tests can then appeal that decision and can get that test done. So join together and figure out how you're going to be a part of changing this status quo. And that's a huge way to educate. You then explain to your employees why you're not paying for mammograms before a woman is 50, why you're not paying for tests that do not show results that are helpful and in fact lead to false positives that lead to additional tests and lead to additional expenditures.
So even though it's just the 5 of us sitting up here, I'd encourage people who want to join in the discussion or ask questions or make comments to go to the microphone as well. I'm thinking about the people who are employers and imagining them explaining to their employees why they're not going to cover certain tests or procedures, or even thinking about where things are gray. Maybe benefit plan design isn't the right type of instrument to use to make the point. Maybe it's more about education. Yes, question.
Ann Lewandowski from the Rural Wisconsin Health Cooperative. In helping patients come up with their own sets of values, are there tools, surveys that they could take and then share with their providers to say, I have a less than 1% of a better cancer outcome for 5 years, I don't really want to move forward? Are there any sort of things that maybe providers could provide in their locations that then patients could take to their visits?
Yeah, so kind of like a self-test or something that would allow patients to be thinking about in advance preferences or their risk tolerance, sort of like when you go see a financial planner. Do you know of anything like that?
I think it's a great idea.
Yeah, it is a great idea.
There are definitely resources out there. So the first thing is I'll remind you that the Center for Patient Partnerships, where I'm from, has student advocates who provide free support for patients anywhere in the country. So please refer your employees to us if they have these kind of questions. There's a wonderful book called A Port in the Storm that is about medical decision-making, and afterwards I'm happy to find it and make sure people get the resource. There are decision aid guides that really help you to think about some of the questions that you'd want to discern as a patient for various issues. There's a website called Choosing Wisely, and it offers many, many different decision aids. There's a portal for patients, and there's also a portal for providers. And I'm happy to talk offline about other resources.
Andy, you've commented about your experience as a clinician. I wonder if you're the exception rather than the rule, and if you can be thinking about now your colleagues and give us a sense of how they're viewing shared decision-making. You noted, or maybe it was Erik who noted, that physicians also tend to overestimate the benefits and underestimate the risks of treatment, but I bet, and tests, but I bet that they don't think they're doing that. So how is it that your colleagues are responding to this movement toward shared decision-making and even OpenNotes? Can you comment more generally?
Sure. You know, my colleagues are varied in that I have primary care colleagues and then I have specialty colleagues, and I am much more interactive with the specialty colleagues. And a lot of what I discuss with my patients is actually at odds with what they may have discussed with the patient. So it does actually set up a bit of a wall, but I've had them contact me on a regular basis, and I tell them this is what we talked about, this is the information I gave them. If you have other information that disputes this, let me know. I want to make sure I'm using the most accurate stuff. And almost all the time, I think we as doctors believe that we have to do something. For instance, when my patients with dementia will go to a neurologist, they will get an MRI again even though they've had one. They will start them on dementia medicines even though the benefit of these medicines is negligible, and they will continue to increase it and change them. We just feel as though we have to do something, and we often don't believe that doing something could be just having a discussion. And that's what I try to convey to my colleagues, that the satisfaction of having that discussion is actually doing something. And that's where this has to change. And it is, again, it's a pervasive problem in the medical field, that we are reactionary, that we don't like to prevent problems, and we like to jump right in and fix things. It's hard, but we do it both globally by their organizations that work to educate doctors, and we do it by having the patients educate the doctors, which has happened a lot when they come in with information. That's why having employers discuss things with patients, Choosing Wisely is another wonderful site. Also, having that happen before the visit is very empowering, and actually I've seen some doctors really change their pattern based on that.
So, Kate, did you have something that you wanted to add just then? Okay.
No, that was an excellent answer.
Andy, I was thinking about when we hear about problems and things that have to change in healthcare, I'm always thinking about, okay, what's our role? How can we use who we are to make an impact? And certainly employers being able to educate their employees about some of these things is important. We're also buying healthcare. We're buying healthcare together through the Alliance, who's contracting directly with physicians and hospitals. And so I'm finding myself thinking, how is it that we could pay differently for healthcare to encourage some of the things that you're talking about? Have you given any thought to how payment redesign could help reinforce the types of things you're talking about, or even the adoption of OpenNotes?
I mean, payment redesign is a big topic that, unfortunately, all the things being talked about in Congress right now have nothing to do with payment redesign. They have to do more with how people are insured, and it seems like nobody wants to tackle that issue. From the perspective of a primary care physician, my idea of payment redesign would be to enable you as a patient to have a doctor, nurse practitioner, or some type of provider who you could count on as your ally, and that person will be paid in a way that would make more people want to go into that field. and then that person would help you through the healthcare system. There are places around the country that do things that way, but very often they resort again to the doctor being the one who sees people every 10 minutes and fills out the note. And I think what we have to do is move toward a system of paying for longer visits, paying for time, and enabling that level to be built up. I found that I was in a conference with Care First, and they I'm part of what's called an accountable care organization. I don't know if you guys know what it is, but you will.
We know the words.
But they were saying, we incentivize you guys in primary care to make sure to send people to the cardiologists who do the fewest, that we know which cardiologists are doing way more stents than other people. We know the stents, they're not effective. And we're going to we have red and yellow and green for these cardiologists, and we're going to give you a little extra money if you send people more to the green. And I put up my hand and said, why are you having the red people in your network? You know these people. Why don't you get rid of them? And they said, no, we want you guys to be. We want to empower you. So I do. I do think there's more that can be done to know who the bad actors are in our field. There are some, and to encourage again more of this bottom-based, time-focused approach to discussions, which tend to have the most benefit.
As I said before, money talks, and if employers are paying for tests and procedures that are not, in fact, advancing health, that is not a good investment of your money. There are lots of ways to move that money upstream into prevention and community health, and so however we can help to do that in partnership, and it is going to take education, right? And I think one of the things we always need to remember in terms of shared decision-making and patients' experience is our history. For some patients, the idea of having less health care will not feel like a positive thing, right? If historically they've felt like they haven't had access to care, the idea that we're now going to take care away is really confusing. So I think these are not easy conversations to have. These are ongoing conversations to have at work and in our religious centers and in parks and in forums like this. And we just need to keep moving the dial from all angles.
I do just want to add that the takeaway part can easily be more than compensated by what you will give in its place. I worked in a group that was the insurance was capitated, which meant we were paid a certain amount per patient, and it was run by primary care. And we kept people out of the hospital by providing home care. We gave people free exercise club membership. We gave them dietary counseling. And what they couldn't get was more than compensated by that. And people joined this plan in droves. Because I think people understand that's what they want. And also that we gave them time, which they adored.
And that's fundamentally at odds with the paying for volume, which is what, as long as we continue to pay for volume on a volume basis only, then we're not going to get to that kind of a place.
And that's what these conversations really help, right? If someone understands that their quality of life is going to be incredibly enhanced if they decide to have less intervention, and they're going to get more time with their grandchildren, and they're going to get more time to be in nature, and they're going to get more time, then that will often be what's chosen. But what's important is to have these real conversations when you're not in stress and when there's enough time for them. So another resource to use to have value-based conversations is advanced directives. So sitting down and talking about a living will and talking about power of attorney and doing this at the kitchen table with all your family members and starting to have real and honest conversations about what's important to us in terms of our quality of life and the end of our life.
Kate, let me ask you, I can see OpenNotes being a real facilitator of greater patient engagement that can help patients prepare for things, but it isn't widely adopted yet. Mm-hmm. If we want to see our doctors use OpenNotes, what guidance would you give to consumers about how they can push for greater adoption?
So there's a couple of things that I think could happen. One is just on the, because you are a payer, you're in a unique position. So that patients can ask for open notes, and we encourage patients to ask, and we have materials, and we encourage patients to ask for their notes. Even if your provider doesn't do it, ask. Ask to have the note printed out. Start getting the idea in the clinician's mind that this is something that they should be doing. One of the things that we are interested in sort of learning more about is what happens if you're the buyer, so you recognize open noters in your directory of physicians. You star this person shares notes. You give some kind of a recognition to them that allows patients to see, oh, that person is doing this thing that I heard about, that my friend gets to have at their provider's office. And it helps give patients a way to know where could they go to get this. And then I would encourage employers to include information for their employees in the benefit package that says, here's places that do it, and if your provider is not on this list, here's how you can ask for your notes.
That's a great idea. Do you know what the response from physicians has been when patients say, can I have a printout of your notes? What should we expect if we take a deep breath and ask that question?
So I will tell you my own experience with a clinician who was not on OpenNotes yet, who, when she asked me what I did for a living, and I told her, said, well, I'm not going to hold that against you. And then I was trying to see what she was writing on the screen, and she went to move the screen so that I couldn't see what she was writing.
All right, you're Elaine.
Yeah. So, but that's not someone that I would go back to again. So I would expect the clinician to be surprised. That's the only negative experience that I've had, though. I would expect them to be surprised, but to say, sure. Many of them will say, well, I'll have to send it to you later because I finish my notes at night, or I'll send it to you when I sign it. But I would expect mostly that they'll be surprised, and then they'll say, oh, sure, and they'll figure out a way to do it.
I do think part of it is how you ask, right? If you say, I want a copy of my notes because I don't trust you, right? That's,
right.
That's not building the partnership. If you say, you've given me a lot of really good ideas to think about, and I need to make sure that I'm doing my part in keeping my health, it would be helpful for me to have a copy of the notes so that I can share them with my partner and family. That's part of continuing a dialogue, and really, I think, resonates.
Lots of offices have adopted the post-visit summary, basic information. So how is that, that's my question, how is that different than what you're talking about? Because I could see a physician responding with, here, I'll give you your post-visit summary.
So the after-visit summary should be something that's very useful. And it, in the end, has turned out to be something that's not very useful. It's a printed out piece of paper that you might get, or you should be getting, when you leave the visit, and it tells you things like your BMI and your blood pressure, and it might have some templated information about the whatever you went in for. So let's say you have a cough or you have sinusitis. It has some standard information about sinusitis and some standard information about treatment. It's not about the interaction that you had with the clinician. So it's very impersonal. Many times it doesn't really apply to you, and really, do you need a record of what your blood pressure was on the day that you went in for that particular visit? So it's something that that practices do to comply with meaningful use regulations, but it's not something that's very helpful for patients.
Not that meaningful.
Not that meaningful,
Yes.
the non-meaningful use.
We're close to the end of time. That sounded ominous, didn't it? I'm wondering if you have any questions that you'd like to ask each other. If not, I'll give you an opportunity to make one final closing comment to the audience. Any questions for one another?
Just one question about OpenNotes, which I think is amazing, and it took us a lot of courage to do it, because sometimes we write stuff in there that it's between us and ourselves, so we don't do that anymore. But there are a lot of specialists, for instance, whose notes print out 10, 12 pages long. And I find them personally undecipherable.
Yes.
And how do you deal with that situation?
So So there's a couple of suggestions. So we don't really give a lot of feedback on this is how you should write your notes or not. Beyond try to stop using acronyms. So for example, one that we always talk about is, patient comes in and presents with shortness of breath, which would be, the acronym would be SOB in the note. So we, suggest maybe you think about not doing that. But the specialist notes are tricky, but the patients still want them, even if they don't understand. And patients, we found, are extremely resourceful. They either have someone in their family who is a clinician, or is a nurse, or is a radiology tech, or so they have people that they can go to. We also think we should be getting paid by Google because they look in their note and then they go right to Google to see what's there. But whether patients totally understand the note or not, they still want it. They still want the information.
Question?
Oh, absolutely, yes, please.
The discussion has been focused on conversations kind of early on in most cases where people may be considering tests or whatever. Do you have anything to say about how this takes a somewhat different form when you have a very serious illness and you have someone trying to make decisions about what procedures to have or not have procedures at that point? And one other element of this, it would seem to me, and I wonder if this is correct, that we spend a lot of money doing things near the end of life that are not productive, but occasionally over the course of time, having done that in a lot of ways that were not productive, we actually discover some things that are very productive and very powerful medicine. And do we endanger losing that advancement by just saying, stop these things?
The end of life issue is a big one, and about a quarter of Medicare's budget is spent on the end of life. But again, having this discussion beforehand makes a huge difference. And unfortunately, that's often what's skipped as we're chasing all these blood tests and cholesterol and EKGs. We don't talk about this very important issue of what you'd want to do at the end of life, who's going to make those decisions for you, how effective are certain procedures and interventions. Similarly, if someone is being rushed to the hospital with an appendectomy, funny story that I think Erik will let me tell. But Erik went to the hospital with a heart attack, and he's an active guy, just came out of the blue and he's fine. But in the hospital, I called up the emergency room, and the nurse said, I said, listen, how's he doing? What's going on? He said, listen, can you talk to him? He keeps asking for the risks and benefits of the stent we need to put in. But there comes a point where you just have to obviously bow down and do what the medical team is suggesting. What happened in Erik's hospitalization subsequently, when he still had a lot of big decisions to make, the team kind of pounded him with information without being willing to discuss it. And I think those were urgent decisions, but they weren't that urgent. They were urgent to the point these techniques could be used. Because we know, for instance, they wanted to put him on warfarin. We know there are pros and cons to that, and they didn't explain that to him, and they felt it had to be done immediately. So there's a certain degree of immediacy where these techniques can still work. The absolute take out the appendix, it becomes more difficult, and the discussions in advance mean so much.
At our center, the Center for Patient Partnerships, the majority of the patients that we advocate with are facing a cancer diagnosis and are trying to unravel really complex information about treatment decisions. And this is absolutely crucial at that time. So, for example, what a student advocate will do is help a patient to research and interpret the standard of care options as well as clinical trials so that when they get into their appointment with their incredibly busy oncologist, they are positioned to be able to have a fruitful discussion about what the real options are. And then if it's a situation where insurance won't cover something because it's considered experimental, we're there to help with those insurance appeals. So shared decision-making is important through the life course of care, and there are advocates and educational materials to support it.
Sarah, I think you've started us with our closing comments. Eric, do you have one that you'd like to make?
Sure. I just think people should probably spend more time thinking about the uncertainty which is inherent in medicine. And they ought to think a little bit more about what risks really mean, and that there's no clear-cut answer. And what makes it more difficult is I think doctors think they're supposed to not do that when they're talking to patients, that they have to be strong and have decisions and make decisions and clear-cut decisions. It doesn't exist. So I think if people understood that very simple thing and then began to understand a little bit about absolute and relative risks, it would begin to change the dynamic of what reality is and what we're supposed to think it is.
Andy, any closing comments from you?
I mean, I'll just repeat what I've said a couple times, which is that I think patients who are empowered can change the entire system. And, you know, I think employers can help with that. And I think ultimately we have to get doctors on board too, but that's going to be a slower process. I think at the level of the employer and the patient, a lot can be done.
And I'm just going to agree with that and comment that as employers, you are in a unique position to work on patient engagement, and patient engagement benefits employers in that patients who are engaged in their care have better outcomes, they make better decisions, and they have better quality of life.
It really, really can be a win-win partnership. So let us know how we can help as you move forward to implement it.
Well, I want to thank you all for a really thought-provoking morning. I think you're right that we want there to be one right answer, and the reality is there's not. And so it's important for us to engage and be part of deciding what we want. So thank you very much for really some eye-opening thoughts. Very thoughtful.